We've got an exciting afternoon planned for you. I'm Piyush Malik. I will be your host for the next few sessions. And the session we now have for you is Big Data Plays God. Yes, personalized medicine and quantified self. So to conduct that session, we have a distinguished health professional, and I would call her Jan Oldenburg. She is the moderator. Jan, please come on the stage, and as she comes in, she would be introducing rest of the people can come in as well. So Erin from GE, they'll introduce themselves. Nigam, Dr. Nigam Shah is the only doctor on the panel, plus he's an academic from Stanford. Tanveer, Shannon. Tanveer is an IBM fellow, and obviously all of them will introduce themselves. So let me first introduce Jan. Jan is a fellow for HIMSS, Health Information Management Society, and passionate about using digital tools to build healthcare systems. She has been in advisory services for E&Y, as well as the Vice President of Patient and Physician Engagement at Aetna. She has also been associated with Kaiser at some point, and of course, she is active on social media. She's written books, and so on and so forth. I would be not doing justice to the panel, so that's why we have a very specialized and qualified panel out here to talk about personalized medicine. So take it away, Jan. Next 29 minutes.
Great, thank you very much. I think we're going to have each of us do a very brief introduction. I think we'll consider myself already introduced. And I want to ask Dr. Tanveer Saeed Mahmood to do a quick introduction of herself first.
Hi, I'm Tanveer Saeed Mahmood. I guess by title-wise, I'm a recently appointed IBM Fellow. And for those who don't know, IBM Fellow is a scientific honor, a technical honor, also for business impact as well. So my background is in computer vision, pattern recognition, applied to medical imaging. And so for the last few years, I've been working in clinical decision support for healthcare.
And now, Dr. Evren Eryuchek.
Hi, I'm Evren. I run the software for GE Healthcare, and it goes from the devices that we use for diagnostics imaging to cloud computing for all your genomics and life sciences, and I'm looking forward to it, and this is a great crowd in here.
Dr. Nigam Shah.
I'm a professor at Stanford, and my 2-minute intro is actually going to show up as a video, so I won't say anything else.
It's not going to show up as a video. Sorry.
That's fine.
The video.
Give
us a quick.
I deal with multi-million patient records in order to identify what is the best treatment for a new patient that walks in the door.
And Shannon Rigo.
Hi, I'm a genetic counselor in Mike Snyder's lab at Stanford. Our lab specializes in creating in-depth molecular profiles of individuals, and my particular role is to look at genomes, understand what's medically relevant for our individual participants, and report it back to them.
So as you can see, we've got a wide range of expertise on this group, ranging from really looking at the depths of the genomic profiles from a personalized standpoint to the analysis of the data to get the profiles. And what we want to talk about today is what this holds in terms of the promise for where healthcare can go and where medicine can go. So I'm going to start by asking the panel to consider what the greatest opportunities of these capabilities coming together really are. And we're going to try to keep this whole thing a little discussion-oriented rather than rapid-fire question and answer. So everybody, please feel free to riff off of one another as we go forward, and we'll see where this takes us. So who wants to start?
Why don't we start with you?
You're
the doctor. You're the qualified one. You're all doctors.
Exactly. We're all PhDs here, probably. So at least on Stanford campus, the thinking is that there's three kinds of precision medicine, which we cover under the umbrella of precision health. So there's precision in the science of medicine, which is the media version of precision medicine, where let's measure a zillion variables on one person, their genome, metabolome, microbiome, what have you, and then decide what's good for them. Then there is the precision in the practice of medicine, which is an Indian walks in the door with borderline cholesterol. Are you going to give a statin or not? Framingham is not useful for you. Can we look through the other 2 million Indians worth of data and make a better decision for the next patient that walks in the door? So that's precision in the practice of medicine. And then there's the third aspect, which is precision in staying true to the patient's best interest. Because medicine, the industry can fight till the very end and rack up multi-million-dollar bills for a person, which is not always in the best interest of the person. And so there's a lot of conversation around end of life, what is in the interest of the patient, and personalization in a way that maximizes their quality of life as opposed to just the scientific advancement of medicine. So all of those three things are encompassed under the precision health rubric, and all of them are around data and using data in some form or fashion. And what I would sort of want to open up for discussion and for the other panelists is that how do we create the right incentives for a data economy to take shape around all of these three things?
I think it's a great pitch. It's a good starting point. I'll build on it. One of the things that we find that's very interesting is if you look at it, the traditional approaches to diagnosis, to care delivery has been around kind of do something, capture it, and use the broad strokes of providing the care. Well, this is it's a stroke, it's going to happen this way. Now, with the refinement of the data, use of the data, use of the individualized data, actually we can hone in on an incoming, like you said, a person coming into the office, and if you actually have information about that person, their horizontal medical records, or the instance of the CT and MR and what have you that you brought in, matching with it and where they are living, because that really is important. Even if we are living in here, we have some history in the other places, that actually changes and has an application to it. Where I see the biggest opportunity for us, going back to your original question, how the clinicians like the Stanfords and UCSFs, the UCSDs and global players and the technical providers like ourselves coming together to really make this available, because there is a huge wall that I'm noticing in the healthcare. I don't know why, but they love their walls. Nobody wants to share data. Nobody wants to make it available. It is impossible to break down those walls. And I think as consumers, as individuals, the better access to people, the smart people have access to those data, faster the solutions we will have. So many of our partners, many of our key opinion leaders that we work with globally, we're trying to actually break this down. Free the data. That is the biggest opportunity we have, and we can use your help, guys.
So on the question of data, I think that you have to look at not just data, but also knowledge. This is often gets buried in from observations that, particularly with the emergence of machine learning techniques, there's a popular impression that you can throw to a machine learner all sorts of data and it'll figure out everything that it needs to figure out. But that's not how the clinicians are working. So they need explanations of why do things happen in a particular way. So there is a combination of data and knowledge that together will drive towards precision medicine. I started out in this field being a big believer in data, as you all know. And we took a slightly different approach to personalized medicine. So on the one hand, doing completely statistical approaches and going from population stats and making observations versus going to a per person, per gene, that kind of an approach. So I think the balance we found was somewhere in between, where instead of drawing from the overall population, you still explore in the neighborhood of your patient using this concept of called patient similarity. This is something that we introduced back in maybe 2004 2004-2005 timeframe, which we have successfully productized and taken to market as well, trying to explore subsets of the population that are more relevant for your patient. So this gives you sort of the happy medium between being totally personalized, just one person cure, and therefore maybe not economical, versus trying to do what is general across the population. So in order to do that, you need knowledge derived from such population groups that are closer to you, understanding what makes patients similar. So this is data-driven knowledge. That's another thing that comes together is the blurring between knowledge and data at that point as well. So these are some things that need to be considered for precision medicine.
And Shannon, you're actually counseling individuals about their data. What are you seeing in that encounter with the person?
Right. So I think for the participants and the patients that I see, one of the greatest opportunities that they really appreciate is the chance to not only have more control over their healthcare when we talk about results of whole genome sequencing, for example, but the ability to make better, more informed decisions about their whole lives. So if I can tell a participant, for example, that I know that they have an increased, let's say a dramatically increased risk of developing Alzheimer's in the future, many of our participants wouldn't want to know that information. But many of them say, if I know that, I'm going to live my life differently. I'm going to make different decisions. They also feel that that information can have impact for other family members, for their children. So I think having that kind of information and being able to make decisions about it going forward, about how you're going to live your life, is really a fantastic opportunity.
I'm also going to just note that one of the other factors in this is the attitudes and the belief systems of the patients. And so as we think about the opportunities here, there's a real opportunity to use the information and data both to consider how we approach people on a very individualized basis, to figure out what motivates Jan differently than what motivates the other people up here, so that we can figure out engagement strategies that are more likely to work and meet people where they are, but also so that people can become more partners in their own care. And as they understand more about their data, their information, that we can help them to understand what actions they can be taking in partnership with their clinicians to drive the right treatment options. Yes.
So another big opportunity that I would want to highlight, particularly to this audience, is the opportunity to define how is success measured. Because healthcare is a complex system, and complex being an understatement. It's complex not because it has too many moving parts, it's complex because incentives are not what they appear to be. And how do you evaluate progress and success in such a system? It's an engineering problem, and at the same time, it's a behavioral science problem. And it's a big open opportunity. We don't know what it means to succeed in precision medicine. And you can't leave it to the docs.
Or the government.
Or the government.
Or the government, right? Because a lot of people come with, can we put some regulations and can we do this and that? And it actually doesn't work. You really have to. And I like the way that you approached it. It's personal decisions are going to matter, how we're going to take advantage of it.
That is the dilemma that we face, is there is a lot of information that you can now easily acquire. We could talk about sensors and how people are wiring themselves to get all of that data. But lots of data doesn't necessarily mean, a benefit, and there could be a lot of noise. So what we are actually reaching in healthcare is a place that it's not that we don't have enough data. There's a lot of, and acquisition is actually quite easy, but it's the analysis and summarization and ways to convey meaning captured through the data in an easily understandable manner to both the patients and the physicians alike. This is one thing that I particularly focus on, is how to summarize what you find and what is important for you to see. So the data deluge problem is very much present, and particularly for radiologists and cardiologists who deal with lots of imaging data. And with growth of high-resolution scanners, this problem has actually become worse. And I know I can probably, you may have felt the same, as many as 100,000 images a day, an average of 2 to 3 seconds per imaging. So having lots of data means you are also more likely to make mistakes. So think in terms of spurring growth in this area technologically, thinking of ways of simplifying the data is just going to be just as important as collecting the data.
This is also a discussion that happens in the realm of personally generated health data. And one of the great debates when you get somebody who is invested in the quantified self movement together with a doctor is often about what data matters. Mm-hmm. And the person's perspective on what data might matter is often very different than a physician's data. And they, if you've ever been a witness to one of those or a part of one of those discussions, it can be very heated. And yet I think it's part of the mystery of this is sometimes we don't actually understand which patterns are useful, and we're still learning that.
Yeah, and it's also important to not always listen to the health establishment. And I'll give a very concrete example. Loneliness kills more people than high cholesterol. And I'm not exaggerating, and back them up with citations and all sorts of studies.
You can all stop taking your cholesterol pills now.
But see, if you compute on incomplete information, you get what I call giga-scale computing, garbage in, garbage out computing. And it happens all the time that you're dealing with some fragment of information that you have access to, either in the EHR or the patient reported or something. You completely ignore the surrounding environment, and then you keep treating that number, the LDL level, to death, and not knowing that grandma is lonely and depressed, and that's why falling every 6 days. That's the challenge. We are turning the personalization, which is a combination of behavior, sociology, and technical challenges, into a purely technical problem. Now, some people might call that a barrier or a problem. I see it as an opportunity that this problem of social behavior technology together has been solved in other domains. There's multi-billion-dollar companies built on solving those problems. Why not in healthcare?
You know, back in the early 2000s, I think, Intel did some ethnographic studies where they actually looked at the impact on the elderly of various things. Like they looked at actually having a presence light, where when elderly populations could just see who else was awake at the same time as they were, it had a significant impact on alleviating their loneliness. They didn't even have to call. They just knew that they could, that somebody else in their circle of family and friends was awake was enough to make them feel less lonely. So it's actually sometimes surprising how little it takes to make a difference in these areas.
I know that, I don't know about Fitbit, if they can solve that or not, but I know that the home health, and they actually do try to, if you look at the companies, startups in their area, they do try to tackle, and it's one of the aspects to it, what can they provide so that there's enough information and activity with the elderly to provide
all that points to is modeling and going from data to semantics and understanding what the data is trying to tell you. So blindly collecting the data and trying to extract statistics from it may not be the right way to go in future, trying to understand what the data is telling you. So that's the balance I was talked about earlier in terms of data versus knowledge. Is gathering
the curation of the data is what we refer to it. If you don't curate it, and if you don't know what you're looking at, I wouldn't know the healthy heart from an unhealthy heart, or you would fall into the pattern of here's a bike and here's the tire. Well, the healthy heart versus a stroke candidate is quite different, and you really need those deep clinical expertise to identify what the data is telling you, and then you can actually do your outliers and go after it.
So the question is that how do you take such complex data, for example, a genetic test, and go to payers like Medicare and convince them that this is any good?
And also, the affordability, because
The-
the plans don't pay.
Yeah, and how do you convince of the utility of that? So the typical thing that happens when any new technology comes out is the people who invented it says everybody needs it. Okay, because of course you want all the 6 billion people on the planet to get sequenced or genotyped or what have you. But it is possible to use data that you have available, and there's examples of this we do at Stanford. So pharmacogenomics was all the rage a couple of years ago, and then the FDA basically cracked down and saying, no way, we're not recommending blanket pharmacogenomic testing. Fine. But you can look through the EHR data that you have, and for the drugs that you know have pharmacogenomic testing or have variation because of genetic variation, and count that how often does it happen that someone gets prescribed that drug and in 30 days needs a dose change or has an adverse event. I can quantify that. And then for the 80 or 90 drugs that could be tested for, I can prioritize them and say these 10 are the most risky. And then you go and say, I'm not saying everybody should be tested, but those people who are on one of these 10 drugs, and based on other people, I predict a probability that 70% chance they will have an adverse event, they should get tested. So you can use data to target. Now, the tech community has solved ad targeting, retargeting, and retargeting ad nauseum, okay? I searched for a desk once, and it's still chasing me on Amazon and every place I go to. Why can we not do that? That kind of prioritization and ranking using multiple modalities of information so that you don't go to a payer and say, everybody needs everything, but you say, these 10 people need testing.
And that would save money, too.
Exactly.
And I will add to it, the other aspect to it is actually technology is evolving so fast. Not only is it chasing him for that selling desk, the technology has reached a point, actually, I know startups, and they're very close to breaking this through. They're going to have genomic sequencing down to $15 a pop. Yeah, and so you won't even think about some of these things. And I know companies out there, they're trying to break through some things that we couldn't even think about it. That's the power of, if you look at the environment that we're in. This is all about startups. This is all about innovative solutions. So we have to really turn it upside down. The way that we did the payer models and so forth are going to go away. And if I were to challenge this audience to go and disrupt something, that would be the insurance companies. Go disrupt that industry. Really. If you think about it, it's upside down. Go disrupt it. We will find a way to really deliver care in a much more affordable way with the help of the technology, with the help of the clinicians.
I mean, there was a mandate to roll out decision support, but due to lack of technology and adoption, it didn't quite happen this year. Otherwise, that was the rollout plan from the mandate. But it is what Nigam said, it's about analysis. It's about quantitative data that shows the benefit of doing one versus the other option or not doing that option. And it always comes down to the economics of it. If people see the benefit, they'll pay.
Look, it's great comments, and I would do exactly what you said. I wouldn't go to a doctor who's do the dicing out there. But it is that type of technology that we're seeing, and we're actually seeing the progress of it. And when you look at a jet engine, it might be a little different because you know how the physical model of it and what the statistical model of it working. It's a little bit difficult for an individual to really build a thermodynamic model or a neural network to really create a model that can actually come and create it. This is where the physicians, this is where the clinicians, this is where the individual's judgment come into play. And I think they will always play a huge role there. I think all these things that we're talking about is going to, in the end, help them get to a decision faster, but I don't know that we can do it without the individuals really work, the clinical work that they are doing it.
We are many years away from even a full part list for medicine. We're learning new anatomy, believe it or not. People have found lymphatic system or lymph vesicles in the brain recently in this calendar year. So we're still learning new anatomy. And so getting to a stage where we have a fully mechanistic understanding, where we can have a deterministic simulation that says, for you, if you do this, this will happen. We're way far from that. Till then, we have to figure out a way to bridge from where we are to that stage using probabilistic methods.
And the combination of knowledge plus data, as we mentioned before, is precisely that. Where you have that knowledge, you do want to employ that. And current analysis techniques actually have to bring that into the picture before they make these recommendations. So it's not all about probabilistic analysis. It is about combining knowledge as well. But as Nigam said, that knowledge is still growing and is incomplete.
So I think in my work in genetics as well, it's a very common thing that we'll identify a mutation in a family that causes disease, about 60% of the time, 70% of the time. So what's up with that 40 and 30% that's left? And we kind of wave our hands and say, environmental factors and other genetic factors. And that's, where the state of things are for so much, for not just genetics, but for other areas of medicine as well. So I think that in a lot of parts of medicine, even if your doctor isn't presenting it as this is the best case 70% of the time for a heart condition, for example, that's still the case. It's just not necessarily told to you because that complicates things. And for a lot of folks, they don't want to deal with that level of uncertainty. But as precision medicine improves, I hope that folks have more of a hand in their own health care.
I think that one of the things that you can take away from this is that this is a rapidly changing area of medicine and a place where the promise both of the medical technologies and the data technologies are coming together to accelerate on both sides what's possible. So I think we're at the end of our time, but please join me in thanking this auspicious panel.